Welcome to the Hill's Bang for Your Buck, Get the Most from your 2026 Medicare Drug Benefits event. As the government shutdown stretches on, uncertainty is rippling through agencies, budgets, and the millions of Americans who depend on federal health programs. With major changes to Medicare prescription drug benefits slated for 2026, the timing couldn't be more critical. What do beneficiaries need to know for Medicare open enrollment, which is already underway, running October 15th through December 7th? To kick off our event, please welcome Bill Sammon, SVP of Editorial Content at The Hill.
Good morning. Thank you. It's easy to understand why there is so much uncertainty, and not just among the people who are inside our federal health agencies writing up budgets for next year, but also uncertainty among the millions of Americans who are relying on these federal programs in their daily lives. So the timing today really couldn't be more critical as we grapple with a number of very pressing questions, including the following. What do beneficiaries need to know about Medicare open enrollment, which, as I mentioned, is already underway? Is the Medicare prescription payment plan actually helping those who need it most? Will selected medications be available at community pharmacies? How can you be sure you're getting the most out of your drug plan benefits? And finally, how can beneficiaries and advocates shape the next round of negotiations? Well, we hope to get some answers to these and other questions today in our program. We also hope that everyone will follow along the conversation on social media using the hashtag #TheHillHealth. Let me repeat that, hashtag #TheHillHealth. With that, I want to take a moment to thank our sponsor, the Alliance for Aging Research, for their generous support in making today's program possible. In fact, we will now begin the program with a short video from, again, the Alliance for Aging Research. Thank you so much for coming out today.
Medicare Part D is an optional benefit that helps cover the cost of prescription drugs. To help beneficiaries better afford their medications, there is an annual limit on Part D plan out-of-pocket costs. In 2026, it will be $2,100. Having an annual limit is helpful, but it can still be a lot of money to pay. Fortunately, another benefit called the Medicare Prescription Payment Plan helps beneficiaries spread their out-of-pocket costs into monthly installments with no interest or fees. It doesn't cost anything to sign up or use this payment option. However, you must sign up with your Part D insurance plan at least 24 hours before you pick up your prescription. You can't sign up for it at the pharmacy counter. If you switch Part D plans, you will need to re-enroll in the payment plan. You can sign up at any time, including during open enrollment. Once you decide to participate, you won't pay anything when you pick up your prescription. Instead, you'll be billed later by your Part D plan and will pay in interest-free monthly installments. Talk to your Medicare Part D insurance plan provider to learn more and visit www.loweroutofpocketcosts.org.
Now, please welcome Sarah Katt, SVP of Programming at The Hill, in conversation with Adina Lasser, Director of Public Policy at the Alliance for Aging Research.
Good morning, Adina, and thank you for joining us today.
Thank you so much for having me, and thank you to The Hill for partnering with us on this important event.
So let's start with the very pressing issue of Supplemental Nutrition Assistance Program, or SNAP. The Alliance has been very active in advocating for SNAP. We touched on it on the last event that we did together. So before we get started, we wanted to follow up on that.
Yeah, it's a really timely question, and as Bill mentioned, it's something that is at the top of all of our minds. Right now, we are facing a dire public health emergency. 7 million older adults struggle with food insecurity, and SNAP is our best tool for making sure that we're fighting hunger and malnutrition. And it's not just older adults. 1 in 8 Americans benefit from SNAP every month. And what we want is, what we want ultimately is for the federal government to reopen. But we're aware that we're facing an immediate emergency, and people should be able to rely on the benefits that they've been promised. And so we're calling on Secretary Brooke Rollins, the Secretary of Agriculture, to tap into a contingency fund, which is worth $5 billion, to continue funding SNAP benefits into November.
Thank you so much. It is now open enrollment period for seniors and those with disabilities. The Alliance recommends that both current and new Medicare beneficiaries pay special attention to reviewing their Part D drug plan offering during open enrollment. What changes should beneficiaries be aware of?
The first thing that I want to make really clear is that this is the year of any year to shop around. Beneficiaries in Medicare will often choose a plan and stay on that plan for the rest of their lives. Every year, it costs you money to not be doing an active comparison. But this year, especially because there are so many changes coming to the program, it's a year to take a look at it. The first thing that I want to touch on are premiums. Premiums overall, we're seeing a bunch of headlines that premiums are staying the same or going down. But the Kaiser Family Foundation found that as premiums on individual plans might be going up by as much as $50 a month. So just because on average they're going down, that doesn't mean that your plan is going down. So the takeaway is check your plan and compare to other plans in your area. Another thing to be aware of is that there is a $2,100 cap on out-of-pocket expenses for all Medicare beneficiaries. This is automatic, you don't need to enroll in it, and it's a huge change over what existed before, which there was no cap at all. Last year there was a $2,000 cap, and before that there was no cap at all. But that's still a lot of money for most people, and so one thing that we're really emphasizing to take a look at is to make sure that you're looking at how are your drugs being covered with utilization management? Is your formulary changing? Are they in a less preferred tier, meaning that you're going to have more cost sharing? And we're also calling on CMS to be more transparent with that information because it's a little bit hard to find. And so overall, the bottom line is even if you're happy with your current plan, it's worth comparing because small changes in your pharmacy network or your deductible can make a big difference to the costs that you pay.
Thank you. So there's a lot of information and changes that people need to address. So where is a good source for reliable information?
It's a great question. The first place that I want to point everyone is the state health insurance assistance programs. We're actually going to hear from a SHIP expert in Maryland later in the panel, but they are free, they are unbiased, they're run out of your local area aging agency, and they'll give you one-on-one advice about which plan is best for you. They're a really incredible resource, and they're in every state. The next is the Medicare.gov Plan Finder. You can go to Medicare.gov and compare how much does your drug cost at your pharmacy on all of the varying plans. And then, of course, there's trusted nonprofit partners like the Alliance for Aging Research. We have been doing a lot of work, like the video that you saw earlier, to get the word out about what, and of course this event, to get the word out about what changes are coming in 2026 and what we can do. And so we also have a number of partners that we work with, such as the National Health Council and MapRx and the PAN Foundation, who have incredible tools. And so we've compiled all of those resources at loweroutofpocketcosts.org, and I encourage everyone to check that out.
All right, thank you. That's a great website for everyone here to remember. Can you tell us a little bit more about the Medicare prescription payment plan and how that can help beneficiaries with cost?
Yeah, so as the video showed, the Medicare prescription payment plan allows beneficiaries, especially beneficiaries who have that higher deductible or who are meeting that $2,100 out-of-pocket limit early in the year, to spread out their costs over the course of the year in monthly installments that are interest-free. So it's a huge tool for helping to make sure that you're not seeing those costs right at the beginning of the year and having to face them. Like the video said, it's important to make sure that you opt into it. You have to opt in. You can't just assume that you're on it. And you can't pick up your drugs at the pharmacy counter within 24 hours of enrolling. You have to wait that 24 hours.
Thank you. This is all very great and good information.
Yeah.
So let's turn our attention to Medicare negotiated drug prices that will go into effect in 2026. There is great concern among independent and community pharmacies about the financial strain this new policy will cause. Could you talk about why community and independent pharmacies are raising the alarms and how this could impact beneficiaries and their access to essential medication?
Yeah, so as you mentioned, this is the first year that Medicare can negotiate the cost of 10 prescription drugs. And independent pharmacies are raising the alarm because the way that these prices have been negotiated, essentially, they're not getting reimbursed as much as it costs to fill a prescription. And so they're saying, they're small businesses, they're independent, they're in the community. And this is a huge concern for older adults and for Medicare beneficiaries overall because your pharmacist is often the first-line provider that you see, and they're the person that you're asking questions to about your drugs. And so definitely something that we want to be aware of. The National Community Pharmacists Association found that as many as 93% of local and independent pharmacies might not cover at least one of the 10 negotiated drugs. So a huge concern. Another reason to check and make sure that your drug is being covered at your pharmacy, and we're calling on CMS to fix this issue.
Adina, thank you so much for this very informative conversation.
Thank you for having me, and thank you to The Hill, and just another reminder for loweroutofpocketcosts.org.
Thank you, guys.
Thanks again to Alliance for Aging Research for their support of today's program. Now please welcome our moderator for today, Kathleen Koch, contributing editor at The Hill. She is joined in conversation with Kirsten Axelsen, health economist and senior policy advisor at DLA Piper.
Good morning, everyone. Welcome. Thanks for coming out on this chilly fall morning. So as you know, we're here to discuss Medicare Part D, and I know this can be daunting. I mean, it can be confusing. My husband actually, truth be told, worked for CMS for a bit, and when he turned 65 very recently, he turned to me, he said, "Can you figure this out for me?" He said, because you're the reporter, you do the research, this is really hard. And I think that says a lot. So I would love, Kirsten, let's jump right in. And you personally have spent years analyzing the impact that drug pricing and coverage changes have on the overall healthcare ecosystem. So when you look ahead to these changes for next year in 2026 for Medicare Part D, what should we be paying attention to? What do you think is the single most significant shift?
It's important to note that premiums are going up, but also formularies are getting more narrow. So what does that mean? Exactly. A formulary is a list of medications that are covered by your Part D plan and what you will pay for them out of pocket. When I say formularies are getting more narrow, that means drugs are getting dropped off the formulary.
People have fewer choices.
People have fewer choices. Importantly, as Adina mentioned, there is an out-of-pocket cap, which is a tremendous benefit. But if your drug is not on the formulary, you're going to pay out of pocket for that drug, and it does not count towards reaching the cap. So it's incredibly important to make sure that the drugs you need are on the formulary. Because you might say, oh, well, that drug costs $10,000, but I'll pay $2,100 and I'll be done. But if it's not on the formulary, you will pay forever that amount, or go seek patient assistance, of which there are patient assistance programs available, but you could end up in a financial pickle if your drug is not covered on the formulary. The other thing to note, as we've been watching, and including going into 2026, plans have been dropping out. This is not unexpected at all. The subsidy for higher cost beneficiaries, meaning the amount of money the government was giving to cover the expenses of higher cost people in Medicare, was reduced dramatically. At the same time, there's pressure to keep premiums low because that's what people look for. So the only way you can really get less funding from the government and keep premiums low is to reduce what you're offering. So you really need to be careful if your plan is no longer available. And in our research, we've noted in particular in rural areas, there's less access. There has been before. By access, I mean fewer choices of plans. So when you're choosing the next plan, really note carefully, are the drugs on formulary? Also note, are there co-pays or co-insurance? I think most of us don't know what the sticker price of a drug is. So when we're told we have to pay 25% of it, that might be a big number we weren't anticipating. And just be prepared. If you feel like financially, and I'll tell you, when I work through this with my parents, emotionally, they don't want uncertainty, even if they have the money saved. So make sure you're ready for uncertainty if you're choosing a plan with co-insurance, or also maybe you have to go through additional hurdles like prior authorization. And then also just really be prepared. If your drug is not on the formulary, that could be a significant out-of-pocket expense for you, and you want to do your best to find one where your drugs are covered. Even if you have to pay a higher premium, which I know is what most people look for, but do the calculation, is it better off for me to pay a bit higher premium if the medications that I need, which are typically more expensive than the monthly premium, are covered?
I know when we were discussing this prior to the event today, you were saying that seniors really need to think about what prescriptions they may need to take in the future. How do you do that when you don't even, you're healthy now and you don't know what might happen to you 10 years down the road?
It's really difficult, and there are not good indicators for this. In fact, I'm releasing research today where we surveyed people with cardiovascular disease. We did this in conjunction with 2 patient groups and found that some of the measures people would like to know are what % of all FDA-approved drugs are on this formulary. And then we compared it to what's available in the quality measures that people see, the star ratings. So am I get a 3-star plan, a 4-star plan? The stars have been declining over time, unfortunately. But unlike if you go on Amazon or make other purchases where you might be able to read other people's experience, that's not available through Medicare. And so, part of what we would recommend is there should be measures that say this percentage of all FDA-approved drugs for this condition are covered. Because chances are, as we get older, all of us are going to get cancer or a neurological condition. And if you have that happen mid-year and you're in a plan, you're not going to have the coverage. So
But isn't there a rule, though, that there are certain drugs, in certain classes that they have to cover, right? There's a list, correct?
There are 6...
In certain categories.
Yes, absolutely. There are 6 protected classes where the plans do have to cover all or substantially all of the drugs. However, coverage does not mean it's easy for you to get. Coverage can mean there's coinsurance. Coverage can mean there's a prior authorization. Coverage can mean you have to try another drug and fail on it before you get the drug you want. And if you have
the step therapy.
The step therapy. If you have a painful condition like rheumatoid arthritis, that means more pain potentially. If you have cancer, that means you may not be getting the drug your doctor wants for you the first go. So just because something is covered doesn't mean it's going to be easy for you to get. So again, I would say do your best to look at the step edit and prior authorization criteria and then decide, is it worth it for me to go in the less premium plan if maybe there is one that doesn't have the same amount of hurdles available that might have higher premiums? And also just make that decision for yourself. Are you the kind of person who is willing and able to fight for what you need, or would you rather pay a little bit more if you can find a plan that doesn't have the same degree of restrictions?
Some of these impacts that you're describing, you saw this coming 2 years ago. Yeah, and it was for those at home who may not know, it was the Inflation Reduction Act that when that was passed, that mandated this cap on the drug expenditures or out-of-pocket costs to $2,000, then it will gradually creep up. So what are you finding in your recent analysis?
Yeah, and I wish I could say I was really prescient or a genius, but I think a number of us saw this coming. Again, it's the combination of the subsidy for high-cost beneficiaries came down very quickly. There's an out-of-pocket cap, which is a great thing, but it's not coupled with enhanced requirements to keep costly drugs on the formulary. So if you're saying people are going to spend less, the government's going to give the plans less, well, a few things are going to happen. Either plans are going to drop out because they decide it's no longer financially viable to provide the benefit. Because remember, there's 2 types of drug plans. There's one type that is drugs only, and for those...
It's Part D, traditional Part D.
Yeah, the part that they called PDPs. For those plans, the dramatic decline in subsidy, they don't have a lot of room left to remain profitable, and they were already declining. There were already plans dropping out. So we are seeing more plans drop out. We are seeing, and this is something I track with a group of analysts that I work with at DLA Piper. We issue reports where we have seen the formularies are getting narrower. We looked at the drugs that were the most commonly dropped off of the formulary. Half of them were for an orphan disease.
And so the Orphan Drug Act doesn't protect them?
No, it does not require them to be on the formulary.
So just as you predicted, there are people who are having fewer choices of plans and fewer medications to choose from as well.
Yes, and in fact, diabetes medication, which is the medication type most commonly selected for the Medicare price negotiation program, the copays have gone up by $11 to $14 per month on average. So what is happening is, again, what we would predict, the government is going to set the price of these drugs and people won't get any savings. The savings will likely accrue to the federal government.
Is all of the latest information out now about the list of drugs that will be covered by the various plans, the list of formularies? I know when we spoke, because of the shutdown, they hadn't been released. Is that out yet?
The formulary data is not out yet.
Still not. Mm-hmm. So how are people going to make their decisions this year? Don't they need to know what's going to be covered? I mean, that's what we're saying. When you
Yes.
pick a plan, make sure it covers your medication. How do we know that?
It's tough. It is tough for beneficiaries, and I think and it's tough for those of us who want to analyze the effects and be able to kind of call out as a warning system, like this is, you should be aware. Look at your copays, they're going up. I think the formulary data will be released soon, is anticipated to be released soon. And so that will be a resource available for people to choose.
I think speaking of drugs, I think a lot of seniors might wonder, well, if 40% of seniors have weight issues, then why aren't these weight loss drugs that could make us so healthy and save our lives, why aren't they covered? These are the GLP-1 inhibitors. Mm-hmm.
Well, in fact, and there's other drugs for weight loss. There's no coverage for drugs that are for weight loss. And in addition to the GLP-1s, I think there's 7 FDA-approved drugs for weight loss. That was something that was written into the Medicare Part D statute when it was designed over 20 years ago. And including smoking cessation drugs were originally not covered. These were seen as lifestyle choices. We've learned, I think, a lot more about addiction, about obesity since then. And in fact, the exclusion from smoking cessation drugs being covered was removed because we've learned more about the science of addiction. And also there's good treatments available. Unfortunately, with drugs for obesity, even though we know infinitely more about obesity and we know that it is a disease and that just telling people to stop eating or exercising is not effective for the vast majority of them, these drugs still aren't covered. And if they're covered, there will be a short-term cost impact. But we also know that when people lose weight, they cost less and they're healthier. So it's a short-term cost impact that's an investment in future savings and, frankly, the next generation. Not only is obesity costing people in terms of their direct health care, it costs hospitals in terms of staff and injuries. It's a real problem, and there's a great fix. There's a number of great technologies available to help people lose weight that are unfortunately not covered by Medicare.
So this is the first year that the negotiated drug prices actually go into effect in Medicare. It was 10 drugs that they negotiated. So will Medicare recipients, will the beneficiaries benefit from that? Will they see drug costs come down?
It depends. People who have copays, for example, we are seeing those copays, and a copay, remember, is a fixed amount of, your plan says every month you're going to pay $60. And that might go up to $70 next year. And if your drug cost $800 previously and now it costs $400, you're still paying that copay. If you have co-insurance, meaning you're paying a percentage of the price of the drug, then it could be that you'll spend some less money initially. The good thing is that there is an out-of-pocket cap. So at some point, people will be reaching that out-of-pocket cap for their covered drugs. So even if they end up paying, a bit more initially, the people who are definitely not paying more are the ones who have higher copays and higher co-insurance, but don't reach that out-of-pocket cap. And so it's not the case that these benefits will flow necessarily to the beneficiaries.
So looking at what was intended by the Inflation Reduction Act and then what's actually happening, do you think we need to have more intervention by policymakers on the federal level, and I don't know if the state level can do anything to help?
Yeah, I mean, yes, I think something needs to be done about the formulary review process. It's not sufficient to just say a drug is, a certain number of drugs are covered per class. We now know, and there's more research every day, that not everybody is treated by the same drug as effectively as the next person. And just because there's one FDA-approved drug or 2 FDA-approved drugs in a class covering, think about mental health. Think about how unbelievably hard it is to treat depression. We're learning more about how unbelievably hard it is to treat immunological diseases and pain. There needs to be multiple choices available. So whether it's CMS reviewing the formularies or, as I mentioned, some sort of a quality measure that could say, this plan has X% of all drugs covered in these therapeutic categories. So you have a sense of, is this a plan with broad coverage or narrow coverage? Is this a plan with a lot of prior authorizations or fewer prior authorizations? people can only really go and look up their own drug. There's nothing that kind of gives you an indication of, if I get stuck, if I get sick, what's going to happen when I go to get treated. And as we age, we're all going to get sick. We're all going to get more stuff. It's, or hopefully many of us won't, but it is sort of the trend of what happens, right? And so, yeah, I would like to see more oversight by CMS of the formularies, and also better measures that let people know what's available to them in their plan.
So if you could pick one reform idea that you could put into effect tomorrow that would make things better, what would that one be?
That's a great question. Oh my gosh, I wish I had that. I wish I had that crystal ball. It would be the oversight of the formularies and the ability to let people know when. And I'm responding to this in terms of sort of what I think would make beneficiaries' lives better immediately. So the ability to know more strongly what's on the formulary. There are structural changes that you could make to the benefit design, such as changing the way the drugs are selected and the price controls. I don't think those are really helping people, and they're deterring investment and innovation. So, there's other changes I would make probably in the longer term, but that's what I would say. If something could happen tomorrow, it would be to give people a better sense of what's covered on their formulary when they go to pick a plan.
Is there anything that beneficiaries themselves or people watching or people in the audience can do to push back against any of this or to advocate? Because I just can imagine, especially a lot of seniors feeling helpless, feeling frustrated. I had a plan and now it's gone. Or I had these prices and then they were here and now they're there. I mean, what can they do?
Well, I'm going to deflect this one to the Alliance for Aging Research team, because they do have resources and approaches to help people push back. I guess the only advice I would give is, if you're in a plan and your benefits have declined, do your best to switch plans if one is available to you. But again, I'm going to turn the advocacy over to the advocates, because I'm a health economist. I'm going to say they're going to be better at knowing what to do.
You've written a lot about the need, obviously, for innovation, for access, and that mandates may not be the answer. So can you elaborate your thoughts on that?
Yeah, I mean, telling companies to do something and then not supporting them with the right financial structure doesn't work. That makes companies drop out, right? Like, if you put in incentives to develop a new medicine, we've seen a lot of companies go after priority review vouchers or invest more in therapeutic areas where there's other incentives that either give them more time on the market or faster review by the FDA. If we make it a category difficult to be in, and I think we see that in antibiotics and vaccines, where there's fairly low rates of reimbursement. There's a lot of liability involved, in particular in being in vaccines. We've seen companies drop out from investing. So you can't just direct something to happen. And also you have to think, and I think that's also what's happening a bit in the Medicare Part D benefit, is we've cut a lot of things, a lot of reimbursement for the plans, and then we're expecting them to offer the same. And which is why there's a big premium support program going on right now. The government had to step in and offer additional money to the plans. Otherwise, the premiums would have gone up a lot. And that's a temporary program. And we're going to be facing pretty soon a situation where, if that premium support comes off, people are going to be paying a lot more per month for their drug benefits.
What about the issue that Adina touched on in the first panel with some of these independent pharmacies who find themselves in the position of someone coming in with a prescription that they have to fill, but they have had to buy the drug at a higher cost than they can sell it? It's every transaction like that for them will be a money-losing prospect. How do you stay in business that way?
Something needs to be figured out, because also think about this, especially these first 10 drugs and even going forward, they're choosing among the costliest drugs to the government. A drug can be costly to the government in two ways. It can have a high price tag, or a lot of people can take it. And in this first 10 drugs, a lot of people are taking them. And so you're going to have people going for their anticoagulants, for their diabetes medications, chronic disease medicines that you're not supposed to skip, and the pharmacy can't go underwater. It's not like pharmacy margins are enormous, right? Like they're pharmacies. They're struggling already. We're seeing pharmacies closing all the time. So we can expect that these drugs are going to be stocked. No business owner would do this, right? And when you're in the position of healthcare provision, it's even more urgent, but we can't expect that a business is going to just be able to stay underwater and float the difference and stay available. So they're just not going to stock these drugs. So like any price control situation, we've got the government setting the price, and it will result in shortages.
Shortages. Shortages of needed medication.
Yes, and not shortages in the way we think it's not produced enough, but if it's not available at your pharmacy, that feels like a shortage just as much because it's not there for you when you go.
So who does that impact most then? Does that impact beneficiaries in rural areas, in urban areas?
More in rural areas than urban areas because there are not as many pharmacy choices. It affects people who rely on community pharmacies that don't necessarily, that don't have the ability to manage that risk.
So I know people may say, well, I'll find another way to get my prescriptions. Trump RX, right, was introduced earlier this year. There's Mark Cuban's operation that also offers low-cost drugs. Are any of those something that are helpful to Medicare beneficiaries, to seniors?
I mean, people should look into it. So far, there's a fairly limited number of drugs covered in the Trump RX program. You can also go directly to the company's, website. Many of them have patient assistance programs. Similarly, with the, with the tools, other types of tools, and also make sure that it really is a better deal for you. I think if you look at what the copays are or what the patient assistance amount might be directly from the drug company, you may find that you could pay less doing that than you might through Trump RX or another. So just shop around, but remember that's time-consuming and hard. So if you can find coverage through a Medicare Part D plan, that is going to be the most time-efficient path to getting your drug.
Right, and obviously you want to hit your cap.
Yes.
Right.
Yes.
And, because then everything's covered after that.
Absolutely, and that's another good point. If you're going to patient assistance or you're going to pay out of pocket directly, that is not helping you reach that cap.
So when we look down the road to the future, what's around the corner that people need to be thinking about in the way of policy changes, maybe not for 2026, 2027, 2028? Can you look around the corner for us? Crystal ball?
I'll do my best. Okay. I'll do my best. So, another 15 drugs were selected for the price setting. It's getting more into the oncology arena. And so we'll know the prices for those drugs that were set by the government shortly. The next tranche of drugs that are going to be selected are going to be both physician-administered drugs as well as pharmacy drugs. When the government sets the price of those, it's going to affect what physicians get paid to use those drugs. And similar to the pharmacies, if physician pay goes way down, you may find either physicians not willing to administer those drugs or practices not being able to sustain themselves financially. Perhaps more of them get acquired through private equity and other arrangements, so you may see some impact on the physicians that are available. And then, we're also starting to see already changes in investments, whether early stage investments. When I talk to investors, they have a decent grasp of the Inflation Reduction Act. And what I hear is there's so many uncertainties in drug development. There's so many ways this can fail. Why would I also be pursuing a drug that has a big Medicare population and might have a price control? Like, why would I add that other element of failure when there's so many other promising areas of science to prosecute? So I would be watching for the impact of this on investment in drug development and on investment in post-market study, which is the kinds of things you do after a drug is approved. You study it maybe in frail elderly, you would study it in children or other comorbidities that are typically not included in the regular clinical trial. So that's what I'd be watching for is, are we gonna see differences in the quantity of clinical trials that are initiated for new or post-market medicines?
I want to jump back to what you were mentioning about physicians. So you said there could be a reduction in these drugs that doctors administer in their offices. They may not want to. So what are we talking about? Who does that then affect?
Those drugs are, physician-administered drugs tend to be for cancer, for immunological conditions. And I don't want to get too policy wonkish, but the way physicians are reimbursed right now is they buy the drug and they get reimbursed the drug's price plus a bit. And that amount of money that they keep is part of what sustains their practice, right? That's part of what pays for administering the drug, the nurses, the staff time.
These are expensive.
These are expensive. And so if you're dropping the price of the drug by 50%, that physician's pay just got dropped by 50% for administering that drug. So they may switch to drugs that don't have a price control, if that's available, which costs more money for the federal government, and patients if they're paying 20% out of pocket, if they don't have a Medigap or other wraparound plan. But also if it's a certain class where there's only one drug available and that drug has a price control, the physician may say, I'm just not going to stock this one anymore and administer this one anymore because I'm not able to sustain my practice economics.
So patients would just have to shop, go from doctor to find someone who would administer it.
And people with serious conditions who already have to go to the doctor to get infusions. Yeah.
And then you mentioned drugs that are being dropped from the formularies are most likely, or what you're seeing, is that they're frequently these orphan drugs. So what's happening now to that community? What are their options?
If they can find another plan that does cover the drug, then they may be able to get coverage. If you can't, then it's going to patient assistance or trying to get help through a foundation.
How exasperating is this as a policy analyst to see the direction we're going? I guess, did lawmakers not get this when they passed the Inflation Reduction Act?
I don't know what they got or didn't get. The Inflation Reduction Act reads very emotionally to me. It has a lot of things in it, the government setting the price, the differences on the biologics and the small molecules. It doesn't hold together from any kind of economic perspective or improve healthcare delivery. I mean, even just the fact that they're targeting drugs in Medicare, many of whom are already deeply discounted. The prices the government's getting is already what the market was getting. Says to me it's more of an emotional than a rational decision. And also just going after the drugs in isolation from the hospital payments or the physician payments is not a way to save money. Either you're going to reduce the drug spend and end up with more medical spend, or it's just, even if you are successful in reducing the drug spend, it's not going to save the Medicare program. So it doesn't read to me like it was done thoughtfully. It feels like it was done punitively. And that's frustrating, because also the federal government's not saving any money. They've already had to give back in premium subsidies the amount, or possibly more than the amount, they saved with the first 10 price controls. And then people are spending more. So it's not even saving money.
So when you talk about the need, though, for a fix, what are the odds in this Congress?
Oh, gosh. I'm
People
not going to predict anything about this Congress.
to make the system work.
Yeah, I'm not going to predict anything about this Congress. I am going to say I think a lot of seniors are going to be unhappy when they see their choices. And let's be hopeful that's motivating.
And they will
call
their congressmen and women?
Or call the Alliance for
Senators?
Aging Research and find out what to do. But yeah, I think this is going to drive a lot of discontent. Like, wait a second, the government's setting the price. I was supposed to get all these savings. And I don't feel like people are going to think they're saving money.
So your dad, what's he saying to you as he's looking at this? Is he shopping? And
I mean, yeah, my dad's taking one of the 10 drugs that has the price controls. And he called me and said, it's so exciting, I'm going to save money. And I was like, Dad, I don't think that's the case. So, and I know many of us help our parents choose plans. Older people really want financial predictability. In my experience, my dad wants financial predictability, and it's not coming to him, and I think that's very frustrating.
so do you leave the stage today optimistic, pessimistic, hopeful? What would you say?
Hopeful, let's say. Let's say hopeful. I am hopeful that people will engage, reach out to their members of Congress, complain to their plans, and ask for better coverage, but also ask for better indicators of what's really covered in their plan, so that they can have a hope of making different choices. But I do want to say, if you're in a rural area and there's 2 standalone drug plans available, there might not be better choices. And that's, again, the concern I have with all the plans dropping out, is the way the drug benefit was designed is, it's okay if you want to go with a cheap plan and narrow coverage and that's your preference, but then there's also this other plan that has better coverage, it's a little bit more expensive. When you start losing that variation, then you start losing the ability to pay for what you need, which I think people are willing to do if they have that option.
Kirsten Axelsen, with Senior Policy Advisor with DLA Piper. Thank you so much for your insights.
Thank
really
you.
Excellent. Thank you very much.
Thank you. Thank you.
Now joining Kathleen, please welcome our panel of Medicare experts. Julia Schreiber, Program Director at the Maryland Department of Aging and Administrator of the Maryland State Health Insurance Assistance Program. John Blum, non-resident senior scholar at the USC Schaeffer Institute and former Principal Deputy Administrator and COO at CMS. Kristi Martin, Director of Healthcare at Camber Collective, a mission-driven consulting firm, and former Senior Advisor and Chief of Staff at CMS, and Dr. Phillip Duncan, an Associate Professor at Virginia Commonwealth University School of Medicine and member of the Association of Black Cardiologists. Welcome all.
So, good morning, everyone. Thank you for joining us. I'm going to start by going down the line. I'd like to know what each of you, so we're looking at Medicare open enrollment during this period, and the changes that are hitting us in 2026. What stands out the most to you, and how is 2026 different from previous years? Let's start with you, Kristi.
So I'm from the State Health Insurance Assistance Program, and we offer free, unbiased counseling to Medicare beneficiaries, their loved ones, and caregivers. I'm actually going to touch on a change for 2026 that's a little bit unique. For those that are considering Medicare Advantage plans that also provide prescription drug coverage, when searching on the Medicare Plan Finder, it now has provider directories. So beneficiaries will be able to search based on the providers that they actually see. And this is a big new development. Inevitably, there are going to be quirks that need to be sorted out. So CMS is offering a temporary special enrollment period in 2026 in case a beneficiary makes a decision based on information that was inaccurate or incomplete from these new provider directories.
So Julia, that goes how far into 2026?
It's for the full year, but right now it's just for 2026. There's a temporary special enrollment period. So I advise this year in particular, document. If you're searching on the Plan Finder, maybe save some of those details, print them out in case you need to access that special enrollment period next year.
John?
I think in some respects, this year is not dissimilar from other years, thinking about the Medicare program. The Medicare program has had choices as part of its kind of overall structure going back into the 1980s. Those choices are more plentiful today than they were back then, obviously, but I think this is really a time where all Medicare beneficiaries, their family members, their advocates should take time to think about what coverage options are best suited for their own circumstances. I think the one thing that Medicare beneficiaries really need to think about is that healthcare needs change over time. And so the plan you're in today might not be the best plan for the future. And so I think that's really what beneficiaries need to think about, what their needs are today, what their needs are going forward. And particularly in the Part D benefit that I'm sure Kristi will talk about, is that benefit now is designed for those that have higher needs, catastrophic needs, cancer diagnosis. And I think this time element gets kind of underplayed during the kind of open season messaging. But beneficiaries' needs change over time. That's part of life, and taking that into account, both the current needs but also your future needs, is really, really important. And some beneficiaries might be better off staying with traditional Medicare and thinking about standalone Part D drug coverage. So this time element really needs to be factored in, and those that counsel beneficiaries need to ask that question: how do you think about your benefits today, but how might you need to think about them, say, in 6 months, 12 months, or even 5 years?
Kristi, what should we pay attention to?
Yeah, and I don't mean to be a Debbie Downer, so I'll start there. But with some of the staffing changes that have happened over this last year at CMS in particular, unfortunately, we've lost some really important people in the Office of Communications and some of the people that have helped train the brokers and agents and the SHIP counselors that helped us get ready for open enrollment every year. And so this year, more than any other year, I think the SHIPs are vital for people to help make those choices. So I'd encourage people to reach out to shiphelp.org, reach out to their state health insurance assistance programs to get that help and make sure that they're picking the right plan for them this year. Plans change every year. People's needs change every year. Along with that, there's the Extra Help program that can help defray the cost of Part D premiums and out-of-pocket costs in the Part D program. Eligibility in terms of like what income level and limited resources that could make you eligible for that program shift every year with, the differences in, how much we have inflation changing. So you could be eligible this year and weren't eligible last year. So check to see if you're eligible for those types of programs. The Medicare Savings Program, the SHIP counselors can help you with that as well. So that's really important. And I think, also we've been talking about the Inflation Reduction Act this year. The maximum out-of-pocket limit for the Part D plans is $2,100, which is still incredible to even have a maximum out-of-pocket cap in the Part D program and in the Medicare program. So I would highlight those changes and then, again, just reiterate making sure to go to the SHIPs and asking for that help because it's really important.
Phillip, as a doctor, what stands out to you?
So when I look at the changes coming, I think that for those who are savvy, who have access to the internet, and I think there are opportunities for them to choose the correct plan.
But that doesn't describe everyone.
Exactly, and the concern that we have is one, health changes quickly. So your situation on November 1st may be very different on March 1st. And so a plan that looks great on November 1st might not be the plan for you on March 1st. And in the Medicare age group, of which I'm a member, you can't, those things can come even more rapidly. So I look at this and I say that, each year we make these changes and we tweak things around, around the edges, but in the end, we have to have some kind of substantive change that recognizes that health is an important non-renewable resource that everybody deserves. And so I'm hopeful that these small changes will get us moving, but I recognize that we need larger system-wide changes and approaches to how we deal with healthcare drug benefits.
Julia, what are callers when they're calling into the SHIPs? What are they asking about most? Is it this reduction in the number of the Part D plans? And if so, I mean, what do you think are the ramifications of that?
So we are getting, the majority of the questions that we get are the right questions. So are my medications are going to be covered? Are they on the formulary? How much am I going to be paying at the pharmacy counter? Are there coverage restrictions? So I highly encourage asking these questions. We have absolutely seen an influx of calls around people asking, what are they going to do? What do I need to do? I got this termination notice. My plan is not renewing next year, so I have to select another one. As SHIP counselors, we do our best to find an alternative. But I will say that in Maryland, and I believe this is a trend across the nation, and I'm hearing from my peers in other states as well, we have gone from 10 Part D, last year we had 14 Part D plans, and in 2026 we'll have 10 Part D plans. And then for Medicare Advantage with prescription drug coverage, we've seen geographic consolidation. So longstanding plans that were offered maybe across the state are now solely in certain areas. So the options are they're still there, and beneficiaries should be considering them, as has been said. every year. But as that choice diminishes, it can create some real challenges.
I'm curious what your SHIP advisors, when people call in, what are they telling folks when they say, hey, is my drug on the formulary if the formulary list isn't out yet?
So there's information currently in there, so they can make the best decision that they can with what's there. One thing that we note is that during this particular open enrollment period, that if you make a decision and enroll in a plan now, you actually can switch plans as many times as you need to within this Medicare open enrollment period. So that's not an ideal situation, but say you enroll in something now, you do have the option. Now for the Medicare Advantage open enrollment period, January 1st to March 31st, for those that have Medicare Advantage, you can only make one change during that period. But now there's a little bit more flexibility.
So if you, I mean, open enrollment started, I guess, a couple weeks ago, right? So if you already made a decision and then you realize you've made a bad decision, you can change it before, which is December 7th?
December 7th, yep.
Okay, fascinating. John, what are your thoughts on the future of Medicare Part D drug plans? And the way things are looking, the future is not bright, but I understand, we have, obviously this year, as Julia explained and Kirsten also, we have fewer choices than ever before, but I understand you say that the beneficiaries want fewer choices, and that sounds a little counterintuitive to me.
I think it's a real important question of kind of how much competition we need within the Part D program in order to get the best value, to get the best experience for beneficiaries. I don't necessarily believe that the number of Part D plans is the right number for us to focus on, but is there sufficient choice? Do we have competition? And what I heard during my time from serving as CMS from the SHIP counselors is there's too many choices. And beneficiaries really struggle with how to evaluate 15, 14, 25 different Part D plans that's being offered to them. I think one of the questions for the future should be, what is the right number? How much competition do we need in order to get the best value? What's the right experience that we want to offer to beneficiaries? And I think what I heard during my time at CMS is that beneficiaries want choices, but they want to be able to feel confident they're making the right choice. And so I think that should be the metric of, do beneficiaries feel they're getting value? Do beneficiaries feel they're confident making choices? And that to me is the ultimate metric, not do we have 10, 14, 25 different Part D plans, but the metric is, do beneficiaries find value? Do they feel confident they're making the right choice? And what I heard during my time at CMS is there is more choice than any one person can sometimes handle, and that's a concern that we should be worried about.
Kristi, you played a central role in implementing the Medicare drug price and negotiation program. Are the results that we're seeing what you expected and what you hoped for? And if not, then what needs to change?
Yeah, I think with any program, especially a new program in the federal government, there's always some anticipated changes you would like to make over time. And especially with this program, we implemented it, I think, in record time. We were given a very tight timeline, but overall, I'm very proud of the work that the CMS team did. I think they did a phenomenal job, and it was a true negotiation. And I think if you asked, and if you looked at the shareholder reports that came out, the shareholder calls that were done, a lot of the statements by the CEOs and the media reports afterwards, they gave very positive statements about how the process went. And overall, we did get very good prices. The Medicare Part D market is an interesting market. The prices that the Medicare Part D market had before were not the same as the commercial market because of some of the financial incentives that were in the Part D market. It's not the same as other private health insurance. And so I think that, over time, the team will get more sophisticated in their negotiation. I think the second round, they will outperform the first round. because they've learned over time the nature of the drugs that they're negotiating right now is a very different set of drugs. So, I think that there will be tweaks over time like any federal program. But overall, I think they've done a stellar job, and I think they will continue. And ultimately, if you have to look at the Inflation Reduction Act and the Medicare provisions as a package. The point of the negotiation program was to generate savings to enrich the benefits of Medicare. And that was the out-of-pocket cap, the $35 insulin monthly cap, the no-cost vaccines that were delivered, the other pieces of the puzzle that actually delivered the enriched benefits to the beneficiaries, expanding the extra help program. Those things we're extraordinarily proud of, as well as the negotiation program.
Phillip, as a doctor, I'm curious. So you've been a cardiologist in nearby Richmond, Virginia, for decades, right? So how have you seen these high out-of-pocket drug costs impact your Medicare patients specifically? And are you seeing any improvements in recent years as these changes that we've been discussing are going into effect?
So high out-of-pocket cost is unfortunately, it's a travesty because we have so many wonderful therapies available to patients, and these therapies continue to improve, and we get new meds and better outcomes with various conditions like heart failure or the new meds that we treat patients with, for example, atrial fibrillation. The issue is that while things can be done on a programmatic basis, things can be done in terms of looking at more choices, medicine is actually very personal. And so for some of the patients that we see, a $45 copay is just as significant as a $500 copay. At the end of the day,
so 45 may as well be 1,000.
Exactly.
Wow.
So when we look at that, we have to rethink how do we look at healthcare and understand that there are things that can be done on the macro basis, but it's personal. It's about relationships and those things that improve our health. And if you look at our health statistics in the country, and you look at our life expectancy actually plateauing and maybe falling for various reasons, including COVID and drug epidemics, but you look at that and you say, okay, if you're not getting the results that you want for us as a group, we need to look and say, okay, how do we readjust this, refigure this so that we see that improve?
And as a cardiologist, when your patients don't take their meds, the result's pretty serious,
right?
Well, what do you see?
Well, what happens is patients might have a copay that doesn't allow them to take a medication for a certain period of time. So, for example, someone has a heart attack, if they get stents, there's a certain set of drugs that they need to take for up to a year that if they miss it, they may have another heart attack and come back. Patients with, like I say, atrial fibrillation, abnormal rhythms, there are drugs that they can take that if they don't take them, they can have a stroke. And that's personal. And when cost is the only barrier to that's a travesty.
Julie, when people are calling in to the ship lines, what are the biggest challenges that your team members are facing in helping them?
I would say, generally speaking, it is it's complexity and misinformation. So when making these decisions each year are not simple. You got formularies and tiering and coverage phases, and these are all technical things that you need to have a strong grasp of in order to make an informed decision. So one of the challenges is putting this information about health insurance into plain language so that beneficiaries are empowered to make the decisions themselves. The other is, we are all, and beneficiaries in particular, are bombarded with marketing and selling of certain plans, and which often highlight exciting benefits. So a benefit card or a gym membership, but they don't necessarily speak to the trade-offs. So working closely with beneficiary to understand what their needs are and really paint the full picture for them so that they can see where their priorities are and make a decision based on the full picture of information.
John, I was wondering, how can CMS better anticipate and respond to some of these unintended consequences that we're seeing, these, because we have these improvements that were meant to reduce seniors' out-of-pocket Medicare costs, and it's not always happening. So I guess what I'm wondering is, do they need to take action, and can they, and rein in things like some of these utilization, management practices, like pre-authorization or step policy that end up limiting access to needed medication?
I think one of the points that Kristi touched upon is just the staff changes that have happened to CMS. And I think in the last several months, that staff is down by about 1,000 people. That's roughly 15% of the overall agency. And overseeing the Part D plans, my experience is that it's a real contact sport. You can't do it through technology. You can't do it through computers. You really need to be talking to health plan CEOs directly. You need to be overseeing the Part D plans to make sure benefits are being delivered consistent with the law, consistent with the regulations, consistent with our values. And I think we are at a real challenging period, and there is change happening to the Part D program, and that's intended because the Congress really wanted to see changes to the Part D program. But we don't have the infrastructure right now in place to really make sure those benefits get delivered well, get communicated well. I think we really have to have a conversation together regarding what is the right staffing needs that we need at CMS. That I would argue strongly that's far too low right now, and that's going to have impact throughout the country. And so the oversight, the management, the delivery of benefits are things that need to be done by human beings. And that's something that is not currently in place that needs to change going forward to ensure that we can deliver the value to the Part D program as intended by the Congress.
Kristi, I was wondering, does CMS need to do anything, and can it do anything to support these independent pharmacies? I know that Adina talked about it. I discussed this also with Kirsten. When they have these cost burdens that it has some of them, what I think it's, according to the National Community Pharmacists Association, more than 93% saying we aren't going to cover one of those drugs that you negotiated the prices for. We can't afford it.
Yeah, so taking a step back a little bit, especially with the pharmacy issues, the pharmacies have been experiencing issues for several years. I mean,
I misspoke. They aren't going to carry. I didn't mean to say cover. They aren't going to carry these drugs.
They've been facing issues for several years, especially the community pharmacies, the smaller pharmacies, the independent pharmacies. This is not just the Inflation Reduction Act. This is long before the Inflation Reduction Act. I think COVID in particular exposed some of their financial issues and the struggles they were having specifically with the pharmacy benefit managers and the plans under reimbursing them, and with some of the issues they were having with the supply chain and the wholesalers and how their supply chains were being set up. And then, then we had started having some issues that they were raising around the Inflation Reduction Act as well. But it's not just the Inflation Reduction Act. And, CMS is very sympathetic to their issues. I think a couple of points to make. One, under the Part D program, there is the non-interference clause. That does extend to the interactions between the pharmacies and the Part D plans.
Can you explain what this is, non-interference clause?
So whenever Congress passed the Part D program, authorized the Part D program, there's a non-interference clause that was built into it. That non-interference clause is most of the time interpreted as CMS cannot interfere with the negotiations between pharmaceutical companies and the Part D plan sponsors. It also means CMS cannot interfere with negotiations between the pharmacies and the Part D plans, meaning what the rates that they're going to be negotiating for dispensing fees, what rates they're going to be negotiating for reimbursements, and how they're going to be building out their networks other than we set network standards. And so that creates some issues with how does CMS get involved and what is the authority for CMS to get involved and what those reimbursements are and how CMS helps to set those rates. We do not set those rates. And so that's always been an ongoing issue. And so then when it came time for the Inflation Reduction Act, and when we negotiated the maximum fair prices or the negotiated prices on the 10 drugs, we started working on a process for how does that flow through the supply chain, ultimately to the pharmacies. And we set up a process so that we could help the pharmacies make sure that they were made whole in the end, to help to facilitate that process. And, ultimately, in theory, the operations will work. It hasn't started yet. It starts January 1st. And I think we'll see how it works out. But one of the issues that I want to also raise is that, and I think the doctor, acknowledged this pretty well, it's not just about these 10 drugs. Most Medicare beneficiaries are not just on one drug. Most take 4 or more prescriptions because they usually have very complicated or complex health issues. They just don't have one diagnosis. They usually have more than one. And sometimes they have pretty complicated health needs that they're trying to address. So if a pharmacy doesn't carry one drug, they also may lose a customer that is also picking up 4, 5, 6, 7 prescriptions from them. So I think pharmacies really have to think about, are they at risk for losing a customer that's actually going to be bringing them more business than just that one drug? So the economics of it are a little bit more complicated than just not carrying one drug. It's about how do they think about delivering for their customer and their constituent that they're serving, not just we're not going to carry one drug out of the 10 that have been negotiated so far.
It really gets complicated.
It gets very complicated, and I think the pharmacies, do have a lot to think through as they go through this process. And CMS has been having monthly calls with the pharmacies to try to help them through and help them to think through this, and they've been, working with them on the operations on how to ensure that they are getting made whole financially through the process of the negotiation program.
Phillip, I was wondering, how often in your office does your staff have to intervene to find more affordable, more cost-effective alternative medications for your patients? Or how often do they have to refer them to patient assistance programs? Or do you have to prescribe proactively? Do you base what you prescribe for your patients on their financial means? And then how does that impact outcomes?
So that's, currently I'm in more academic practice, spending more time in hospitalized patients, but a long history of working in the office. And that's a daily chore with multiple patients, finding out what they have, what they can afford. And on the hospital side, when we have a patient in the hospital, we will do a price check on medications before we discharge patients with a certain pathway, certain prescriptive pathway, which means sometimes we give people less than the best. Sometimes we cannot afford to, or the patient cannot afford to take on those medications that would be in their best interest. And then the other part of that is, yes, there are programs, there are ways where we can sometimes get support for these, but often that's time consuming. It takes time away from staff that could be doing other things that's more patient leaning. It's often complicated for the patients. I have patients who live out in rural areas where they don't have any internet access. They don't have access to the computer. Whatever they do is usually done when they come to the doctor's office and when they interact with that office, and it's what they can do for them. And if their resources are stretched, then it doesn't get done. Patients don't get what they need. And there's one other piece to that too, because what we have now is a system where we have a drug plan, you have a physician or provider, you have a pharmacy. Now, for the patient who's at the center of this, there may be trust in that pharmacy because that's where they went to and that's where they get their medications. There may be trust in that provider, but their drug plan might be covered in a plan that doesn't include these folks over there. And that's a challenge. We forget, again, that personal trust factor that's so important to effective medicine.
But to go back to the prior point you were making, how frustrating is it when you are basing your decisions, your medical decisions, on what people can afford and not what they need?
It's extremely frustrating, particularly when you have a patient who may have done well on a particular regimen for a period of time. They have done well, and then you have to say, January 1, we've got to switch this, or we're going to take you off this and see what happens. It's exceedingly frustrating because we're not offering the best for our patients when we do that.
Julia, what strategies are are SHIPs following to help them to help the people who most need help when it comes to beneficiaries, specifically those who are lower income or in areas where it's just tougher to find the services that they need of all sorts?
So I would say, broadly speaking, one of the benefits of SHIP is, at least in Maryland, is that excuse me, services are delivered locally. So really meeting people where they are, offering counseling sessions in senior centers, in retirement communities, in libraries. The other thing that I would say is, one, there's significant under-enrollment in extra help, so the Part D low-income subsidy and the Medicare Savings Program. So many people that are eligible but are not enrolled. So really trying to raise awareness for that especially during open enrollment. We screen everybody that we see to see if they are eligible for those, even if they don't ask about it. And then also helping people get creative. So when we talk about what options, considering options, we're talking about plans and what choices we have there. But also there's additional programs like prescription drug assistance, we have the Senior Prescription Drug Assistance Program. So for those that don't qualify for extra help, we have some pharmacies. We have a new nonprofit pharmacy that redistributes surplus medications called Good Pill. They're only certified in Maryland, but it's $2 for a 30-day prescription. So there's some, that's unique to Maryland, but trying to connect people with some of these other programs that exist to help them afford their medications.
John, you've written extensively about your vision for rebuilding CMS, the Center for Medicare and Medicaid Services. So what structural reforms do you think that CMS needs to make to ensure, that these changes that we're discussing today, that they better serve all beneficiaries?
I think one of the trends for all three programs that CMS oversees, Medicare, Medicaid, but also private insurance, those programs have been structured by Congress, by law, to really offer choices. And so beneficiaries, whether you're part of the Medicare program, you're part of the Medicaid program more and more, whether you're getting your coverage through the exchanges, you're going to have to think about which plan is best suited for you. I think the skill set for the future for CMS will be more and more to help beneficiaries make those choices, oversee competition to ensure that it's rigorous. Think about mechanisms like risk adjustment and quality ratings that really build strong incentives for better beneficiary value. I think particularly in the Medicare program that it was built and it was staffed to run the traditional Medicare programs, setting fee schedules and setting all the payment levels that are part of traditional Medicare. That's still important, but I think we have chosen as a country, we can debate whether it's good or bad, but it is a choice that we have made to deliver more of our CMS-run benefits, Medicare, Medicaid, and private insurance through competing private plans. And that is a skill set that we're going to have to continue to develop. We're going to have to continue to staff for that oversight, making sure the payment is right, making sure the value is good, making sure we have strong incentives towards caring for the sick, but also to provide best-in-class customer value. And that's a skill set that CMS has today that will need even more going forward.
Kristi, what cautionary lessons for the future can we draw from the healthcare industry's response to these changes to Medicare for 2026?
So I think a couple of things. I think that, we're seeing a lot of things this year in response to, there's a lot of short-term thinking. I think a lot of knee-jerk reactions to some of the issues that are going on. There's a lot of volatility in the healthcare space right now. I think some of the premium reactions are, concerns about what is happening. And so they're worried about, things are going to change, and so they're increasing premiums thinking things are going to change, and they're not sure what's going to happen, so they're reacting to that because they're not sure. And I think the other thing that we can learn too is that we need to just be having conversations about what to expect and what's going on. You know, I think when John and I were at CMS, we made a very deliberate effort to have an open door policy. So anybody that asked us for meetings, we had meetings with them. We were very clear about we wanted to talk to stakeholders. We wanted it to be a two-way dialogue. I think the other thing is we also had a stakeholder engagement plan so that we had regular town hall sessions, we had regular stakeholder calls. We provided opportunities to make sure we were telling people, here's where we're going, here's what we're doing. I think every center had a strategic vision that they put out there very early. I know my boss, Dr. Meena Seshamani, had hers out there within 3 months after I came on board in October of 2021. But every center lead had their strategic vision about here's what I'm doing, and it all followed from John and Administrator Brooks LaSure's strategic vision. And so really like setting out a roadmap so people knew what was happening and trying to create that predictability. And so I think in 2026, that's what people are really lacking. And that's what we need to try to get to, is giving everybody an opportunity to say, here's what's going to happen. And like, let's try to create one dialogue, but also some certainty for the future.
Phillip, I'm going to give you the last word. I'd love for you to give us a message. What, as a doctor, do you want to tell policymakers about Medicare Part D or the Medicare system in general? What would that message be to them?
Medicare Part D, Medicare, I would say that we deserve good health care for everyone. And right now we have an issue where health care is the sun. Many people enjoy the sunshine of good health care and access, but there are people who live in the shadows. And so we need to bring this to high noon so that everybody gets the benefit of the outstanding health care we have available to us in the U.S., but is totally affordable or unavailable to a segment of our population.
Well, everyone, please join me in thanking Phillip, Kristi, John, Julia for your wonderful insights today. We really appreciate it. As I said, this is a complicated issue. We didn't cover everything, but we did the best we could. So it's time for the event to wrap up. But thank you all. Thank you all for joining us here in the room and those folks watching at home. I hope we answered some of your questions. And a big, big thank you goes out to our sponsor, the Alliance for Aging Research. Thank you for making this possible. Now, if you happen to miss this, or you have friends at home who go, oh gosh, darn, I wish I'd seen that. It's all going to be available online, and that will be at thehill.com. So the full video will be there. Well, thank you all. Thank you for joining us. And for those out there making those Medicare choices during open enrollment, good luck. I hope we helped you. So thank you all, and have a great day.